Let's go ahead and learn everything we need to know about Addison's disease. Addison's disease is a disease where the patient does not have enough cortisol, enough aldosterone, and enough androgens. These are all produced by the adrenal cortex. In Addison's disease, which is an autoimmune disease, the body destroys the adrenal cortex, resulting in a lack of these three substances: cortisol, aldosterone, and androgens. Primarily, we're going to talk about cortisol. Cortisol is required by many systems in the body. It helps regulate our blood sugar, it helps regulate our blood pressure, it's involved in the immune system, and so much more. How does it work? The adrenal cortex produces cortisol, and the adrenal cortex gets the stimulation, the message to produce cortisol by a signal from the pituitary. The pituitary sends a signal to the adrenals, to the adrenal cortex specifically, to produce cortisol, and that signal is in the form of ACTH. When the ACTH is high, it means the pituitary is telling the adrenals to produce cortisol. However, if the adrenal cortex is destroyed, then no cortisol gets produced. So primary Addison's disease is an autoimmune disease where the adrenal cortex is destroyed and we don't have the ability to produce cortisol, aldosterone, and androgen. A second way that we can end up with a lack of cortisol is in steroid withdrawal, meaning that a patient has been prescribed steroids, but instead of tapering it, meaning slowly coming off of his dose, the patient suddenly stops taking it. In that case, it's not a problem with the adrenal cortex, but in that case, the problem becomes that the pituitary is no longer sending the signal, the ACTH signal, to the adrenal cortex to produce cortisol, but it does have the same net result that the patient does not have cortisol in their body, or at least not sufficient amounts. We're going to talk about the different treatments for those two causes in just a few minutes. Next, let's look at the signs and symptoms. First of all, classically, Addison's is often a misdiagnosis. It's hard to diagnose Addison's because these symptoms are very slow in onset and they're very nonspecific: fatigue, weight loss, hypoglycemia, abdominal pain, and dehydration. One of the classic signs, and one thing that you will be tested on, is hyperpigmentation. Hyperpigmentation is where the patient gets darker areas of skin. Usually it's classically around the skin over joints, such as the knees or the elbows. Sometimes it could be in the palms. Sometimes it could be over wounds that have since healed and scarred. Those would be the classic places you'd be tested on. But hyperpigmentation is one of the classic signs of Addison's disease, and it has to do with the fact that when the pituitary produces ACTH, it's also producing more melatonin, which darkens our skin. Next, we have, I'm sorry, I said melatonin, I meant melanin. Next, we have diagnostics. So the classic way to diagnose Addison's is ACTH stimulation test. That is cosentropin, which is a medication. And when we give that, we see what happens with the ACTH. Remember, ACTH is high in Addison's because the pituitary is yelling at the adrenal cortex to go ahead and produce cortisol. But unfortunately, in Addison's, the adrenal cortex is unable to produce cortisol. We also check the aldosterone level, which we would expect to be low, and the cortisol level, which we would expect to be low. But again, if the aldosterone and cortisol levels are both low and the ACTH is high, that's Addison's. All three of those are low, that's more likely to be secondary Addison's, also called adrenal cortical insufficiency, also most commonly due to steroid withdrawal, sudden steroid withdrawal. Next, we have nursing assessment. As part of our assessment, first of all, we're always going to investigate the signs and symptoms of the disease. So we're going to ask about fatigue and weight loss and hypoglycemia, but we're also going to look for the risk factors, for the causes of Addison's. Primary Addison's is often caused by infection, by stress, by trauma, and certain medications can all cause a patient to have a low cortisol level and to develop and to have a flare up of Addison. So those are the things we're going to investigate. We're also, again, going to assess for that hyperpigmentation. Sometimes on tests, I've seen it in a few test banks, it's called bronze. The skin is becoming a bronze look. Nursing priority is going to be vital signs because, again, we said cortisol is necessary for our cardiac system as well as most systems in our bodies. So we're going to check that. And we're also going to get the patient their steroids. That is the treatment for Addison's, to get them on steroids. That's going to be our priority. Let's look at the treatment. First of all, if the patient has secondary Addison's disease, meaning they have a low cortisol level just because they suddenly stop taking their steroids, the treatment there is going to be very clearly to put the patient back on steroids, and this time have the patient slowly come off of it like they're supposed to. But let's talk about primary Addison's, the autoimmune disease where the adrenal cortex is destroyed and there's no more production of cortisol. In this case, the patient's going to get started on steroids. Usually by the time we diagnose it, we're starting them on IV steroids. But at that point, once we get them stabilized, they're going to be on PO systemic steroids for the rest of their life. In fact, this is one of the only times ever that we put a patient on PO systemic steroids long term. We always want to avoid that, but in this case, the patient needs it. Cortisol is a corticosteroid. The patient's not producing it, so we give it to the patient. Let's look at the bottom two boxes. We have client education. First of all, they're going to need routine labs very often in order to keep an eye on their treatment. They're going to need to know what stress dosing is. Stress dosing is where a patient is going through periods of stress, and they will be told that you need to take 2 to 3 times your normal dose. Again, this is not, NCLEX is not going to ask you how much exactly, but your school can test you on how much more or what is stress dosing. And it's where patients with Addison's are educated on taking extra steroids when they're going through times of stress, because that's what the body would normally do, but it's unable to in Addison's. They're going to be educated that this is lifelong treatment. They're going to need to take the steroids for the rest of their life. Again, we all need to have that in our bodies. Since they can't produce it, we have to give it to them. We're going to educate them to never suddenly stop taking their steroids. And we're also going to educate them on the signs and symptoms of Cushing's disease. Cushing's disease is the opposite of Addison's. It's where a patient has a very high level of cortisol, but we're going to educate them on the signs and symptoms of it so that they can make sure that their cortisol level is not getting too high. Next, we have complications, and up here, the main complication is the Addisonian crisis, where the patient can end up with hypotension, due to dehydration primarily. They can end up in shock, and they can end up in severe hypoglycemia. Hopefully that covered everything you need to know about Addison's. Almost always this has to go along with Cushing's, which we have in a separate video. If you have any questions, please reach out. Hope you do great in school, and see you in the next video.